In the management of stage 3 colorectal cancer, the cornerstone of treatment is curative intense surgical resection followed by adjuvant systemic chemotherapy. This dual approach is essential. Surgery removes the visible tumor, while chemotherapy targets microscopic disease that cannot be detected at the time of operation. Radical surgery is the critical first intervention. It involves complete excision of the primary tumor along with adequate regional lymph node dissection. This step offers the best chance of cure. However, in stage 3 disease, lymph node involvement signals a high likelihood that microscopic tumor cells remain in the body. Because of this residual risk, surgery alone is not sufficient, and adjuvant systemic therapy becomes necessary to reduce recurrence. Adjuvant chemotherapy is typically initiated about 4 to 8 weeks after surgery, once the patient has adequately recovered. The two most widely used first-line regimens are FOLFOX, which combines 5-fluorouracil, leucovorin, and oxaliplatin, CAPOX, also known as Xelox, which combines capecitabine with oxaliplatin. These combination regimens are considered the standard of care because they significantly improve disease-free survival and overall survival when compared with fluoropyrimidine monotherapy alone. The effectiveness of combination chemotherapy lies in synergistic mechanisms of action. Fluoropyrimidines, such as 5-fluorouracil or capecitabine, inhibit thymidylate synthase, disrupting DNA synthesis and halting tumor cell proliferation. Oxaliplatin, on the other hand, induces DNA cross-linking, preventing replication and triggering apoptosis. Together, these agents more effectively eradicate residual cancer cells than single-agent therapy. Large randomized trials, including the Mosaic and Xeloxa studies, demonstrated the survival advantage of adding oxaliplatin. 5-year overall survival improved from roughly 67% with 5-FU alone to over 78% with oxaliplatin-containing regimens. These findings firmly established combination chemotherapy as the preferred adjuvant strategy in eligible stage 3 patients. Despite its efficacy, combination chemotherapy carries a higher toxicity burden. The hallmark adverse effect of oxaliplatin is peripheral neuropathy. This may present acutely as cold-induced dysesthesia or chronically as cumulative sensory neuropathy, which can become dose-limiting. Other toxicities include diarrhea, nausea, vomiting, and mucositis, hematologic suppression, including neutropenia and thrombocytopenia, hand-foot syndrome, particularly with capecitabine. Because of these risks, patients selected for combination therapy typically have good functional status, usually an ECOG performance status of 0 to 1, and adequate marrow, renal, and hepatic function. Risk stratification further refines treatment decisions. The IDEA collaboration demonstrated that patients with low-risk stage 3 disease, defined as T1 to T3, N1, can receive 3 months of CAPOX with disease-free survival comparable to 6 months, while significantly reducing toxicity, especially neuropathy. In contrast, high-risk patients, those with T4 and/or N2 disease, derive greater benefit from 6 months of combination chemotherapy. Elderly patients, particularly those over 70, may gain less survival benefit from oxaliplatin and face higher toxicity risks. In such cases, fluoropyrimidine monotherapy may be considered a more tolerable alternative. When compared with other treatment modalities, chemotherapy plays a complementary role. Surgery addresses macroscopic tumor burden, while chemotherapy eradicates microscopic residual disease. Radiotherapy has a limited role in colon cancer but is standard in rectal cancer, where it is commonly used in the neoadjuvant setting to downstage tumors and reduce local recurrence. In colon cancer, radiotherapy is reserved for select situations, such as fixed tumors or positive margins, and does not replace systemic chemotherapy. Immunotherapy represents an evolving frontier in colorectal cancer treatment. It is particularly relevant for tumors with mismatch repair deficiency or microsatellite instability high status. Checkpoint inhibitors are now standard first-line therapy in metastatic dMMR or MSIH colorectal cancer and are being investigated in earlier stages. Trials such as NICHE-2 have demonstrated remarkable pathological response rates with neoadjuvant immunotherapy in locally advanced dMMR colon cancer. However, in stage 3 disease, immunotherapy remains investigational and is not yet standard outside clinical trials. In summary, the standard first-line management of stage 3 colorectal cancer consists of curative surgical resection followed by adjuvant combination chemotherapy, most commonly FOLFOX or CAPOX. This strategy is supported by robust evidence demonstrating improved survival through synergistic cytotoxic mechanisms. Treatment decisions must balance efficacy with toxicity, guided by patient fitness and risk stratification. Last seen compiled by Dr. Julius, Independent Medical Educator, Lancashire, United Kingdom.